Günaydın diyerek başlıyorum önce.
Good morning. My presentation will be a bit more clinical oriented. I'm someone who's been involved in therapeutic drug monitoring and plasma concentrations in the last couple of years. Therefore, I will concentrate on this term. Why do we use TDM, and what is TDM actually? When we use lithium or valproic acid, we have to check the plasma concentration levels. We have to do the same for other anxiolytics, for other antidepressants and antipsychotics. We run these tests for different purposes in different drug groups. For example, for some drug groups, we want to prefer toxic concentrations, or if we have, for example, a specific patient group, then we want, such as pregnant women, we want to use the drug at minimum concentrations, or if we have psychiatric patients, then we want to check whether they abuse the drug or not. And sometimes in our clinical practice, we go beyond the indication recommendations, and we use drugs at higher doses. So we want to check whether we are at toxic doses when we achieve clinical efficacy. And sometimes in toxicology, in drug screens, especially after suicidal attempts, we make use of TDM. TDM will be useful, for example, if the drug has a narrow therapeutic range, and if there is a direct relationship between drug metabolite levels in plasma and the pharmacological or toxic effects, and if the therapeutic effect cannot be readily assessed by clinical observation. For example, benzodiazepines. Benzodiazepines can easily be adjusted in terms of their dosages by clinical observation. There's only one exception of benzodiazepines, for example, the use of alprozam in panic disorders. It is recommended to check the TDM to adjust the dose in panic disorders of this benzodiazepine. And it's also recommended to be used at large individual variability in steady state, and appropriate analytical techniques are also available to determine TDM. As a clinician, I make use of TDM very often. For example, in cases of liver or renal failure, in case of there is non-compliance, we benefit from TDM. If there is risk of intoxication, insufficient response in spite of sufficient dose, side effects, drug combinations, they all are important indications for TDM. For example, if we had added fluoxetine to the combination, then we better check the TDM. Suggested drug interactions, relapse prevention, relapse, distinct genotype, children, adolescents, and elderly patients. There are some other special indications for TDM. For example, the lithium concentration needed for acute mania is different, and the lithium concentration for maintenance therapy is different as well. So this is a specific indication for TDM. Of course, the patients run their bioequivalence studies. However, in the clinic, we see that the original preparation and the generic forms are not always the same. For example, fluoxetine 40 milligrams is fully efficacious. However, the other generic form is not as efficacious because the plasma concentration levels are different. And of course, in phase 3 studies, we also benefit from TDM. We started measuring plasma concentrations of drugs at a very early stage. But of course, what difference would it make? I thought at first, because there is blood-brain barrier as well. To what extent does it cross the blood-brain barrier, and to what extent it has affinity to the receptor? But some studies so far showed us that plasma concentrations and brain concentrations correlate well with one another. And for most of the drugs, the receptor affinity rate is also parallel to plasma concentrations for 90% of the drugs. Of course, there are some exceptions of this as well, but the overall result is that 90% of the drugs respond well. There's a table here on the 3 techniques that were discussed so far. Each has their advantages and disadvantages, and TDM measures for that certain drug at that moment, and it responds for a certain drug. It of course gives us an idea about the drug, but if the patient has taken, for example, grapefruit juice, or if the patient has smoking habits, then these should be included as well. It's very simple. TDM is very simple. It requires no preparation. If the patient has not taken any drugs for the last 12 hours, then it's fine. Of course, there are some limitations. We need steady state needed, and the results are only useful for that current drug therapy. Phenotyping, on the other hand, predicts metabolic capacity much better, and it gives us information for all the drugs that metabolize through one enzyme. But there are patients in which, for example, we have low compliance, and urine sample collection can be very difficult because the patients should not smoke and should not take coffee, should not drink coffee either, and this is not always either. Genotyping seems to be very useful, but it is useful. Is it useful in the clinic as well? Well, it is useful actually, but sometimes the resulting phenotype is not always clear, so we cannot really benefit from genotyping. TDM is very useful for us because you see the patient at the outpatient clinic, and you can easily take a blood sample and get the results. There are some limitations, of course. The hospital staff has to be trained. The physicians have to be trained as well. Sometimes the patient might have taken the drug a couple of hours ago, but you still collect the sample, and this is of course an inappropriate sampling, or you don't have a full history of the patient, and you haven't made note of his smoking or coffee habits or alcohol habits, for example. And sometimes, for example, you see that the plasma concentration levels are high, but you do not adjust the dose. I mean, if you run this test, then you have to take the appropriate steps. This is not an automatic process. Once you read the test, you should understand what the test means. Let's say the patient takes the drug regularly, but you have to ask appropriate questions to the patient. For example, the patient takes 50 milligrams of Satarel every day. Have you taken the pill yesterday? You ask the patient, and he says yes, but maybe the previous 4 days the patient did not take the drug because he had run out of the drug. So this might be misleading. So you have to know whether the patient takes the drug at the indicated time as well, and at the indicated doses. I will show you something else though, a very interesting table this is going to be, and you will see some figures on this table, like 1, 2, 3, 4, 5. And this is actually the levels of recommendation for TDM for different molecules. 1 means strongly recommended, and 5 means not recommended. Here we go. Here you see antidepressant drugs, tricyclics, for example. Plasma concentration in the blood and clinical response is very parallel to one another. Therefore, the recommendation levels are 1. But for some others, such as fluvoxamine and escitalopram, the evidence level is only 4. And there are some other, for example, agents that are considered to be probably useful due to the chemical composition of the drug. In some other drugs, for example, where we can make use of clinical observation, the recommendation level is lower. For clozapine, for example, we have to check the blood levels in any case. And clozapine is actually the drug that led us to start testing for TDM. because just like lithium and valproic acid, clozapine is one of those agents that requires dose titration and dose adjustment as a result of TDM, or plasma concentration measurement. But in Turkey we do it by clinical observation, and it's not very useful. But retrospectively, I checked my patients and I saw that 30% of the dosages that I've administered so far were actually wrong. There are some patients, for example, who got intoxicated with only 150 milligrams, but there are those patients, for example, who should receive 900 milligrams, and 500 milligrams in those patients is definitely not enough. About mood stabilizers, let me say a couple of words about them as well. For lithium of course is the drug that we use very often, but carbamazepine and valproates. We don't really know much about the sparing qualities of these drugs. Therefore, we adjust to the anti-epileptic doses of neurology. Is it useful then? Well, to a certain extent, but it is the data for these two agents is not as strong as it is for lithium. Same goes for anti-dementia drugs. Donepezil, for example, is reported to have a higher clinical response if the clinical plasma concentration levels are higher. Methadone is another agent, and again TDM can be used for methadone to see if there's an abuse or not. I will now share with you a couple of cases. This is a 30-year-old schizophrenic, a male schizophrenic. It's a very interesting patient because he's been hospitalized several times, multiple times, and typically when hospitalized the patient gets better, but when he goes back nothing changes, but the patient gets sick again and he's hospitalized again. This has been repeated maybe 12 times. You have 3 minutes, by the way. We didn't change the dose at all. The patient is on clozapine 400 milligrams. The plasma concentration level is 516. Therefore, it's efficacious. We discharged the patient. No problems at all. The patient is doing well. But a couple of weeks later, the patient came back in psychotic state. We questioned the patient. The plasma concentration levels are halved. But when we count the medication, for example, the patient seems to be compliant. Once again, we gave the patient 400 milligrams of clozapine at the hospital. The blood concentration levels increased again. So we had an interview with the family of the patient. At the hospital, of course, the patients can only smoke up to 10 cigarettes per day. But at home, this is a patient who's unemployed and he's a bit absent-minded. We found out that the patient actually consumes 2 packs of cigarettes at the coffee shop each and every day. This, of course, reduces the plasma concentration levels significantly. This is the second case. A 32-year-old male patient with a diagnosis of paranoid schizophrenia for 14 years now. The patient has good response to ECT, but not to any antipsychotics. But we have to hospitalize the patient every now and then because he's resistant to therapy. The patient was receiving fluopantixol depot injections as well as risperidone at 4 milligrams per day. So clinically this is enough. But the plasma concentration levels were found to be very low for risperidone and 9-OH risperidone. So in total, the combination should be between 20 to 60 mgs, but the total plasma concentration was low. We increased the dosage of risperidone, but it didn't change much. The literature says that if the risperidone to hydrorisperidone ratio is more than 0.1%, then this is a clue for UM genotype, and you have to administer higher doses. if, of course, the risperidone to hydroxyrisperidone ratio is more than 1%, then this is a clue for poor metabolizers. So we have to take this into account. Another case about clozapine. This is a 40-year-old female patient who's on clozapine, who's been on clozapine monotherapy for 7 years, 300 to 700 milligrams. But the family says the patient stares into space for a few seconds, sleepiness, muscle twitches, brief loss of consciousness, speech difficulties, and difficulty in breathing. We checked the history of seizures, no seizures at all. ECG looks normal from 5 months ago, but clozapine appeared to be at toxic doses, 890 mgs. We found some paroxysmal activity in EEG as well. We added gabapentin as an add-on to her therapy. We reduced clozapine dosage to 400 milligrams per day. When the plasma concentration levels are higher, of course, higher is the risk of a seizure. In clozapine-induced epileptic seizures, usually valproic acid is preferred. Neurologists usually prefer valproic acid. But when you combine valproate with clozapine, it leads to poorer metabolization of clozapine. Therefore, the literature is now moving towards gabapentin because gabapentin has lower drug-to-drug interaction. And this is my last case, a 43-year-old female patient. She has side effects with all the drugs. She can't stay on any drug at all. She has depressive episodes since she was 21. She was given ECT, and she benefited from it. She used many different medications. The last one was escitalopram, but she had tingling feelings, sedation, yawning, sweating, aches and pains at her back, on her belly, abdominal pain she had, and she couldn't continue the treatment for a long while. Paroxetine, amitriptyline, venlafaxine, these all caused side effects. She was on 10 milligrams of escitalopram, but the blood concentration levels were found to be very high, 126 nanograms. Then we did genotyping on this patient, and 2 enzymes were found to be poor metabolizers. That is, and this is seen at very rare rates within this population, less than 1%. And the drugs that we administer to this patient are 2D6 and 2C19. And these drugs use these 2 pathways actually. So we switched to bupropion in this patient because CYP2B6 was better. The patient also received CBT. We asked to follow up this patient frequently, and the problem was resolved. This is a picture from our previous lab. Thank you very much.